No, you don't see any?
Wave 1.
Okay, we're good.
Okay. All right, so let's start with MitraClip. And I'll just go with the most easy question. What is the MitraClip?
Can I go see if I have one?
Absolutely.
Yeah.
Good.
Let me see. You're going to splice up the video anyway, right?
Speed.
Wave 2.
You're not hitting it twice.
I'm not like Cecil. Okay.
All right.
Come closer, Jason. Just right
Okay.
there. Yep.
All right. So
Let's-
traditionally, what have you done in mitral valve surgery?
So, mitral valve disease oftentimes is mitral regurgitation. It's a leaky in valve. You have two valves, an in valve and an out valve. The in valve and a leaky valve doesn't close all the way. So what we do is traditionally we open a patient up and open their heart so we can sew around the outside of the valve and put sutures, and then take and tighten the valve and bring it closer together. So for example, we take a ring like this, and we take the sutures in the valve annulus, and what it does is it compresses the valve and brings the two leaflets closer together. The difference that a MitraClip does, instead of suturing it and pushing it and pulling it together with a ring, the MitraClip grabs the individual leaflets and pulls them together at the tips of the leaflets rather than the outside. Now, this is unique because what it does, it creates two holes and it turns one valve into effectively two smaller ones.
What are the benefits to a patient of this procedure versus an open procedure?
So this procedure is not designed for everyone. It's still better for a patient to undergo regular open heart surgery because it's very good, and when the risk is low, you get a better outcome and better result. However, sometimes patients are very, very high risk for surgery, and they may not even survive it, or the morbidity would just be not worth doing. So the MitraClip is just done through a puncture in the vein, and with just a puncture in the vein, we can decrease the amount of leaky valve. The recovery is better, and the risk is much lower.
Let's see. What is the research kind of found out where you know to reinforce what you're saying about the called the benefits?
So there's been randomized prospective trials in patients that are high risk for traditional surgery. We found that even though the amount of leak, the reduction in leaky valve, the reduction in mitral insufficiency is better with traditional surgery. However, it's very good with the MitraClip, and it's sustainable, and it's durable, and it lasts quite a while. So overall, if you are a low-risk patient, you probably still want regular surgery. If you're a high-risk patient, you should at least go to a center to be considered for a MitraClip.
Okay. So moving on to transcatheter valve, which we will soon be doing here. Same question. Traditionally, what have you done in helping a patient with aortic stenosis?
So we treat a lot of aortic stenosis and a lot of aortic disease. What happens is the out valve doesn't open so well. So you have an in valve and an out valve. With aortic stenosis, the out valve does not open. Before, the only way to make that out valve open is to take it out and put a new valve in. In order to take out the valve, you need to open someone's chest, open their aorta, take it out, sew a new valve in, and close them up. This has been very good, it's very safe, and in low-risk patients, it's really the right thing to do. However, in high-risk patients who maybe won't tolerate surgery or maybe had surgery before, it's much better to do things with less invasion. So with a puncture in the vein, you can put a catheter in one of the arteries and put a valve in and inflate the valve and just open it up from the inside. So it leaves your own valve in place and just puts a new one in, a little smaller, and forces that your old one to stay open and has a new valve in place that opens and closes. The good news is it's very safe, and in a lot of patients who have no other option, they live a lot longer and feel a lot better. However, in patients of similar risk or low risk, we think there may be a higher rate of stroke, both at the time of procedure and afterward, and there's a higher rate of leak around the valve. Sometimes that valve doesn't fully expand, and so you get a leak in between the patient's old valve and the new one. And if this leak is significant over time, that can cause some problems. However, in patients that are high risk and wouldn't have anything done anyway, this is a perfect option.
Okay. To put it that way then, to say it succinctly, talk about then the same way you did with MitraClip, that it's not ideal for every patient.
So it is a great procedure for the appropriate patient. However, if you're a very low-risk patient, you've never had cardiac surgery before, you have normal kidneys, you're very healthy, well, probably it's much better to have a traditional open aortic valve surgery. The only way you can find out is to go to a center that can offer you both.
Okay. Is there anything you'd want to add about either one of these? I mean, the whole thing will be 3 minutes. I think you've said everything I'm going to need.
So it's all about patient choices. And what we strive to do is provide the best best option for a patient. Now, I think in order to do that, you have to be at a center where a patient has all those options. And only a handful of centers in the region and in the country really can offer patients both a procedure or an open, both a closed procedure or an open procedure for both of these diseases.
Okay, perfect. Easy enough.
Sound good?
Thank you.
Thank you.
Wave 3. You.
Huh?
You need a goalie?
A goalie.
Shortstop?
No. Am I missing?
Quarterback? Oh, it's not. We were talking sports. Weren't we talking sports?
So MitraClip to, get out there that way, but TAVR, that way I've got a video to go along with the release when we're ready to roll. So.
You're going to cut me out? This is just like, you're just trying to make me feel good, but all this video, this is what we call
We don't have any
E-roll, which is like eliminate this. That's
Kay
what I'm
said he was
assuming.
the best cardiologist in St. Louis.
Kay told me that.
He met Marv.
Really?
And,
Well,
and,
Marv's the smartest person in the room.
I know. He knows more about cardiology. All right, so MitraClip and TAVR. So to start at the easiest question, what is a MitraClip?
That's the easiest question.
Okay, well,
Did we not cover this, or did we cover this one?
we've done a different video for it, and I could
It didn't
go
work?
ahead and use it, but I want
Okay.
to have different answers for this video.
What is a MitraClip? So MitraClip is a clip, and it's put in by a catheter that we thread up from the leg that goes up across the top of the heart and angles down on top of a valve, and that valve is called the mitral valve. And the problem with that mitral valve that requires a clip is that it leaks. So blood, instead of getting pumped out to the body so the body can use it, actually goes backwards. It's going the wrong way down the highway. And when we put that clip on, we attach the clip to the valve leaflets to eliminate some or all of that leaking or the blood going the wrong way. We can put on 1 or 2 clips in this hybrid lab as an alternative to surgery for people with mitral regurgitation or leaking of their mitral valve.
And surgery used to be the alternative. Describe that procedure versus what you're able to do with MitraClip.
So there's literally 3 procedures that we talk about and we contemplate with a patient who has mitral regurgitation. There's a mitral valve repair, which aims to preserve as much of the patient's native mitral valve as possible with trimming it and making adjustments to it so that it prevents it from leaking, but it's not an artificial valve. And so the patient's left with their own valve and their own material. The second is a mitral valve replacement, where we take out the old valve and we put in an artificial valve. It can either be tissue or it can be metallic in that place. and so the valve is replaced. Both of those are open surgical procedures. They involve an incision through the sternum or midline sternotomy. It's an open heart procedure. When patients are at higher risk for that kind of procedure, for bad things happening, meaning we're worried about how they do through the operation, we're worried about their recovery, we're worried about meaningful recovery after the procedure, then the mitral clip becomes in play, where we can fix the mitral regurgitation without the big operation, allowing the patient to get some benefit, but it's not as good as the tried and true mitral replacement or repair surgical procedures.
Okay. So the overall pros and cons, it's not for everybody. This is a procedure best suited for those at high risk.
So mitral regurgitation is a spectrum. And patients with mitral regurgitation are on a spectrum. There's no two patients that are alike. There's patients with mild regurgitation, and they sometimes progress. Most of the patients early on in the course don't have symptoms. Patients who don't have other significant risk factors and what we call comorbidities, or other things wrong with them, like patients not on dialysis because of kidney issues, patients who don't have other issues with their heart, they're best suited for surgical procedures because the surgery is an ultimate fix and has the longest durability and longevity to the procedure. The patients who have other things wrong with them and a lot of other stuff, they've had open heart surgeries before, they potentially have kidney disease or other organs which aren't necessarily doing as well, where if we put them through a long operation, we end up possibly making some of those things worse. Those are the high-risk patients that we consider for the mitral clip. So it's a small group of patients across the entire spectrum of patients with mitral regurgitation.
Be able to treat it with the transcatheter approach.
Aortic stenosis is a narrowing of the door between the main pumping chamber of the heart and the rest of the body. So no blood can get to the rest of the body without going through that door. And the stenosis part means that that door doesn't open all the way. And so the blood flow out of your heart is restricted. Obviously, that could potentially cause significant problems. It's like putting a restrictor plate on your heart as the motor, so you can only get a little bit of blood out. And as that continues to narrow down, you get less and less and less. Traditionally, there's only been one alternative to treatment, and that is surgical valve replacement. So when the valve narrows enough, or the patient develops symptoms such as pressure or tightness within the chest, inability to exert themselves, or passing out unexplained, surgical valve replacement was the treatment of choice and has been for decades. And that is the first choice even today, given the fact that we have an alternative now, which is catheter-based valve replacement of the aortic valve, or so-called TAVR, or TAVRs, transcatheter aortic valve replacement. TAVR is for those patients that are high risk for having an open surgical procedure. They potentially have issues where they could be worse off undergoing an operation. Many times those patients are older. Many times those patients have already been through open heart surgeries before, including especially bypass surgery. Sometimes those patients already have weakened heart muscles. We can replace those aortic valves by putting a catheter up from the leg, across where that valve is, and allow a valve to be put where the old valve was, pushing the old valve out of the way and allowing the new valve to be functioning instantaneously in that type of patient.
What are the pros and cons?
So the pro of TAVR, or the transcatheter valve, is obviously that it's not an open surgery procedure. So you don't have to have an open incision through your chest. That means that your recovery time is less and the risk overall for the procedure is less. It's done through the leg rather than the open incision. The downside is twofold. Number one is only a certain group of patients who need aortic valve replacement qualify for this procedure right now in the United States. And those are the patients that are at high risk for an operation or are inoperable, or meaning that a surgeon says they can't operate on them. So it's hard necessarily to fall in that group, number one. Number two, the data suggesting these valves work is very good and shows the durability of these valves out to 5 years. The data suggesting the durability of the surgical valve replacement procedure is several fold longer than that. So that procedure's been around for a long time. It is why that's the gold standard and the tried and true procedure. The transcatheter valve procedure is newer. The data will come and will show us the longevity of the valve, but it's not there yet to this point.
Talk about this room and the importance of having this room and this technology available to you in order to do these procedures.
So this room is our hybrid catheterization lab at St. Louis University. And this room is representative of not just infrastructure, but representative of the fact that people who are considering getting mitral clips, people who have mitral regurgitation, who could potentially have an open mitral valve replacement or repair, people who have aortic valve disease and potentially are candidates for aortic valve surgery or TAVR, these people are best served by seeing a team of doctors and getting a team approach to help care for them and guide them to what the best decision is for them. And every patient is different. In this room, number one, is very spacious and allows a team of people to assist in the care of that patient. So a mitral clip procedure is done by 2 physicians at the bedside doing the procedure, a physician at the bedside assisting and guiding the procedure, performing a procedure we call transesophageal echo, an anesthesiologist, as well as a team of nurses and staff that are within the lab to allow that procedure to be done successfully and for the best interest of the patient. At TAVR, much the same way. It's a team of physicians and a team of nurses and technicians within this lab. So the space is, number one, most important. Number two is we can't necessarily anticipate all possible scenarios. And so this room allows us to be able to offer many different options in worst case scenario standpoints. We aim to potentially implant an aortic valve from a catheter up through the heart. If something goes wrong, if the patient needs to have an open procedure done, we can actually convert that procedure from a catheter-based procedure to an open procedure here to save somebody's life. It's not our first choice, it's not our intent, but we have the capability of doing everything possible to provide best possible outcome for the patient. So it allows us that flexibility to have within this room. It also utilizes the best imaging equipment so we can see what we're doing with the best displaying of those images and the screens behind me with married with the personnel that are aimed to try to take care of that patient.
You were great. Overall, is there anything you want to add that you haven't talked about?
Valvular heart disease procedures and valvular heart disease and cardiology today, these are difficult but frequent problems. And patients with valvular heart disease need to explore their options. My suggestion to patients is that they have to get opinions. They have to get opinions that garner the trust of their treating physicians. And opinions from physicians that they trust should be very meaningful. Opinions from a team of doctors that can offer a wealth of different types of procedures gives that patient and their families the best possible option to treat them. And St. Louis University in the C4 program is aiming to have that breadth of technology with that breadth of procedural guidance to focus on each individual patient separately. That's our advantage, what we've been aiming to try to produce.